Hello everyone. So this session is about cranial nerve 10, that is vagus nerve, and these are the content of the lesson about the vagus nerve. So vagus nerve is mixed nerve, but it is predominantly motor nerve. It has longest, most widely distributed course, and because of its extensive vague course and distribution, it is known as vagrant or wandering nerve. Field of distribution extends beyond head and neck. That means it reaches up to thorax and abdomen also, and it conveys most of efferent fibers of cranial part of parasympathetic outflow and distributes fiber of an cranial part of accessory nerve. So functional component and nuclei for cranial nerve 10 or vagus nerve, these are the functional component. First one is general visceral efferent fibers, which arises from the dorsal nucleus of vagus, which provide parasympathetic innervation to heart, bronchial tree and the most of GIT, general visceral efferent. Then there is spatial viscerant fibers. So these arise from nucleus ambiguous, because this is the nerve of the fourth pharyngeal arch, so it supplies muscles of the palate, pharynx and larynx. Then there are general somatic afferent fiber nucleus. These fibers terminate in nucleus of spinal tract of trigeminal nerve, carry general sensation from skin of the auricle. Then there is a spatial visceral afferent fiber which terminate in nucleus tractus solitarius, which carry taste sensation from posterior most part of the tongue and epiglottis. And then general visceral afferent fiber which terminate in nucleus tractus solitarius and some in dorsal nucleus of vagus, which carry the general sensation from mucous membrane of pharynx, larynx, trachea, esophagus, thoracic and abdominal viscera. So all these are the different functional component of vagus nerve. So here you can see the general visceral efferent, smooth muscles and glands in the thoracic and abdominal viscera. Then there is spatial visceral efferent, muscles of pharynx and larynx, general somatic afferent, spatial visceral afferent and general visceral afferent. Course and relations. So here it arises from the lateral aspect of medulla between the olive and inferior cerebellar peduncle in 10 rootlets. These rootlets unite to form a nerve trunk. You can see here the rootlets are forming a nerve trunk, and this leaves the cranial cavity by passing through the middle part of the jugular foramina enclosed in a common dural sheath along with the 11th cranial nerve. So you can see here the 11th cranial nerve, you can see here the 10th cranial nerve. So this is 10th and this is 11th. Now here, as it is passing through the jugular foramina, it has two ganglia. There is superior and inferior sensory ganglia. The smaller superior ganglia is present within the jugular foramina, and the larger inferior ganglion, which is also known as nodose ganglion, it is present just below the jugular foramina. Superior ganglion has fiber of general somatic afferent, and inferior ganglion has cell bodies of the visceral afferent fiber. The cranial root of accessory nerve, you can see here cranial root of accessory nerve, and here also you can see cranial root of accessory nerve. It is transferring all the fiber to vagus nerve for distribution below the inferior ganglion. So cranial root of accessory nerve fibers are being given to the vagus nerve, and now the vagus nerve will be distributing all the fibers of the cranial root of accessory nerve. So here the vagus nerve is coming out of the cranial cavity through the jugular foramina. First it is running vertically downward within the carotid sheath between the internal jugular vein and internal carotid artery, and then it runs between the internal jugular vein and common carotid artery. This is the vagus nerve. You can see here, this is the vagus nerve. Okay, it is entering the thorax at the root of the neck. The right vagus enter thorax by crossing in front of right subclavian artery. The left vagus enters the thorax by passing between the left common carotid and left subclavian artery. What are the branches and distribution? So you can see here there is one auricular branch, which is also known as Alderman branch. There is one meningeal branch, then there is pharyngeal branch, there is here superior laryngeal branch, there is sinus branch here, but this is actually coming from the cranial part of the accessory nerve but distributed by the vagus nerve. Okay, and here you can see recurrent laryngeal nerve. So the first branch we can see here, the meningeal branch, which is arising from the superior ganglion, and it supplies the dura mater of posterior cranial fossa. Then there is auricular branch, also known as Arnold's nerve or Alderman nerve, which arise from the superior ganglion. It supplies the skin on the back of the meatus and adjoining part of the auricle and floor of meatus and tympanic membrane. Stimulation of this nerve, as in case of syringing of ear, may cause a reflex coughing, also known as ear cough. It can cause vomiting and even it can result in cardiac arrest. Then there is pharyngeal branch. You can see here the pharyngeal branch. It is arising from inferior ganglion. It take part in formation of pharyngeal plexus, which supply, the pharyngeal plexus supply all the muscles of pharynx except stylopharyngeus, which is supplied by the 9th cranial nerve, and also the pharyngeal plexus supply the palate, muscles of the soft palate, except the tensor veli palatini, which is supplied by mandibular division of the 5th cranial nerve. Then there are the branches to the carotid body. They are also arising from the inferior ganglion. Then there is superior laryngeal nerve here. This is the superior laryngeal nerve, which is the nerve of the 4th arch. It is arising from the inferior ganglion. It is dividing into external laryngeal nerve and internal laryngeal nerve. The external laryngeal nerve is motor. It supplies the cricothyroid muscle of the larynx, and also it gives twigs to inferior constrictor and pharyngeal plexus. Then there is internal laryngeal nerve, which pierces the thyroid membrane and enters the laryngeal cavity. It is sensory. It supplies the mucous membrane of larynx above the vocal cord. It also supplies the mucous membrane of the pharynx, epiglottis, vallicula and posterior most part of the tongue. Then there is superior and inferior cervical cardiac branches. They are superior cardiac branch, okay, which carry the preganglionic parasympathetic fibers to heart, and these are cardioinhibitory. Inferior cervical cardiac branch of the left vagus nerve joins the superficial cardiac plexus, and here is the recurrent laryngeal nerve, which is the nerve of the 6th arch, and it supply all the intrinsic muscles of the larynx, which except the cricothyroid, because it is supplied by the external laryngeal nerve. Sensory innervation to the mucous membrane of laryngeal cavity below the vocal cord also is by the recurrent laryngeal nerve. Now applied anatomy. So first is Alderman nerve phenomena. Alderman or Arnold's nerve, the tickling of cutaneous distribution stimulates jaded appetite. So Alderman nerve supply the posterior aspect of the meatus and the pinna, So it can be used to stimulate appetite by dropping cold water behind the ear, which result in the reflex increase in the gastric motility supplied by the vagus nerve to the stomach. Lesion of the vagus nerve. Bilateral lesion can cause nasal regurgitation of the swallowed liquid, nasal twang of the voice, hoarseness of the voice, flattering of the palatal arches, cadaveric position of vocal cord, dysphagia and loss of cough reflex. So all these are featured because of bilateral lesion of the vagus nerve. Clinical testing of the vagus nerve. Patient is asked to open the mouth and say ah. Palatal arches of the two sides are compared. If both vagus are intact, soft palate rises, is elevated in midline. If bilateral lesion is there, soft palate will drop, and in unilateral lesion, flattening or drooping of palate arch on side of paralysis, and uvula is pulled to the normal side. So that is how the testing of vagus nerve is done. These are the references. Thank you.